And good afternoon or evening, depending on where you are. It might even be morning where you are. I thank you so much for joining. And today I'm going to talk about the importance of gaps and minding the gaps. And I'm going to talk about two gaps today. The first gap will be venous to arterial CO2, and the second gap will be end-tidal and arterial CO2. Looking at those gaps actually gives us a huge amount of information that helps us to determine what's really occurring for our patient. So of course, it's really important always to remember what CO2 tells us. I've talked about this a lot. I talk about it a lot in blood gas class, reminding us that with an arterial blood gas, really what we evaluate most particularly is lung ventilation and the remaining acid in the system after lung clearance. So I want to again reiterate to you, lung clearance is what we call ventilation. CO2 in the blood could be a reflective of failure of lung clearance, but it can also be reflective of poor pulmonary perfusion, and it can also be reflective of hypermetabolism at the cellular level. So, by the way, looking at PaCO2 is not nearly as simple as you think. And a lot of times when you see the interventions that you are attempting with patients and you don't see clearance, you need to ask some questions about whether or not you're doing the right thing. Now, with the venous blood gas, as we know, the venous blood gas is the major reflector of cellular flow, of cellular function, of cellular respiration, which is CO2 production, and the acid-base status, which is primarily production of CO2 or production of hydrogen ion and the neutralization thereof. And what's really, really vitally important to remember, wherever you are, if you have an arterial blood gas and a central venous blood gas, you can actually mimic the cardiac output by looking at the venous arterial CO2 difference. We think about how important this is, and then we think about the endpoints of resuscitation. So this is a big discussion in the critical care world today, and it should be in the emergency world as well, is what is the endpoint for resuscitation? Is it SCVO2? Is it mean arterial pressure? Is it lactate? Is it a change in the partial pressure of carbon dioxide? And then we bring together all that information in combination with the end-tidal CO2. And the end-tidal CO2 is really a reflection of pulmonary perfusion, that's Q, and pulmonary ventilation, so not systemic perfusion. End-tidal CO2 is a reflection of pulmonary perfusion and pulmonary ventilation. And we want to remember that whenever we're looking at patients, we're always evaluating their oxygen exchange and their CO2 exchange. We evaluate that in the lung, but we also need to evaluate it in the most important place, and that is at the microcirculation, not really the arterial blood gas, the microcirculation. So we're going to use the perspectives, the exchange of oxygen and CO2, the evaluation of the gas exchange and the ratio of the gas exchange, and the gap to really give us good information about our patient's blood flow dynamics. So if you've been to any talk I've ever done, you've certainly seen this very simple cartoon. That simple cartoon is something that I feel should be in everyone's mind at the bedside of an acute or critical patient. And that is the three categories of carbon dioxide. The most important one is what's being produced at the cellular level. And that's the production CO2. You cannot measure that in the arterial bed. It must be measured in the venous bed. And it's most meaningful because it's looking at a global or more regional indicator if we do it centrally. So we look at production in the venous bed, particularly centrally, as PVCO2, how much carbon dioxide was produced by the cells as blood flowed past, and as the cells are perhaps hypermetabolic, have a high demand, or there is inadequate blood flow or shunted blood flow. PVCO2 really does reflect what happens at the cell. It reflects what the cells have produced. I'm going to go from here over to here. The PaCO2, which is the one we measure the most, the one we're in love with, the one we use to define everything we're doing with a ventilator, but not very much to help define what we're doing with perfusion. And that is the partial pressure of arterial CO2. Now, From a physiologic sense, I'm not talking about clinically. From a physiologic sense, this is the least important. Now, clinically, it's really important to us because it affects vascular tone, it affects our patient's sympathetic stimulation, it affects the ability to perfuse. We're very concerned about it. But here's the fact to remember. This is the CO2 that remains after we've produced it and when we've cleared it. So we produce it at the cell, and it's produced in excess in anaerobic metabolism when oxygen demand is high or when you're shunting your blood, very highly produced. And then you eliminate it, and you eliminate it in your gas as you exhale. So it's quite important for us to recall and really change the way in which we think, because we're so focused at the bedside on the arterial CO2, and sometimes we use the end-tidal CO2. We think it's well calibrated, it's reflective. We want it to always reflect the arterial CO2, but really the value of end-tidal CO2 is when it's not reflecting the arterial CO2. That's when it really tells you the most information. So we're going to spend some time discussing that, trying to make sure that everybody is comfortable with that understanding and that knowledge. Now, I want to remind you again, I'm going to say it probably 10 times during this talk, about vital carbon dioxide measures. Number one, PVCO2, which is an indicator of cellular production of carbon dioxide. And the cardiac output surrogate, which is taking your VO2 and subtracting your arterial CO2. And most importantly for us as bedside providers, those have to be drawn at the same time. So you're drawing an arterial gas and a central venous gas at the same time. And what you're going to get back is a normal arterial gas, a normal central venous gas, and you're going to take the venous CO2 and the arterial CO2 and subtract the arterial CO2 from the venous. That's a surrogate for cardiac output. So you're in a place where you don't have stroke volume monitors, you don't have PA catheters, you don't have non-invasive methods like ClearSight or Starling. You just have a critical patient who's got a central line and an A line. You can still mimic and look at a circuit of cardiac output. And that should be determining what you are doing with therapy. Now, you know, I don't love cardiac output because it's heart rate times stroke volume. But in this case, I'll take what I can get. And if I'm seeing that the cardiac output is low or it's just normal, but the patient is tachycardic, that's always going to tell me I don't have adequate blood flow. So I want to remind you that the production of CO2 is an indicator of cellular respiration, aerobic and anaerobic. Okay, very good, really straightforward. And we understand that in aerobic metabolism, you are continuously producing ATP and using it for glycolysis and building it up again and using it for glycolysis and building it up again. That's really all you have to remember about the dreaded Krebs cycle and the beta hydroxy oxidation chain. What you need to remember is that you make ATP best in the presence of oxygen and you deplete it when you don't have adequate tissue level oxygen. So it really is important to remember that we produce a huge amount of CO2 by normal metabolism every day. Now we're talking about somebody who is hypermetabolic, who's hyperthermic, who's in pain, who's agitated. They're producing a lot of CO2. And really important to remember, the more CO2 you produce, the more burden you're putting on the lungs, and the lungs have to actually work to blow off that CO2 to actually maintain a normal pH. Okay. So from there, saying, I want PVCO2 and I want arterial CO2, and then I want to use my cardiac output surrogate, PV minus A CO2, which tells me about adequate blood flow. We're going to talk about those values in just a moment. The next thing we think about is pulmonary perfusion. And here's what's really important about that. A lot of you have this tool. You're using it all the time at the bedside. You're looking at end-tidal CO2. You're looking at arterial CO2. You're doing an arterial blood gas, and you say, why is it that my end-tidal and my arterial CO2 aren't traveling in the same direction? And they should always. If arterial CO2 is down, end-tidal CO2 should be down. If arterial CO2 is up, end-tidal CO2 should be up. They should always travel in the same direction. But when they are disconjugate, meaning arterial CO2 is up and end-tidal CO2 is down, that's a whole nother problem. And that problem is pulmonary perfusion. Now, we see alterations in pulmonary perfusion with patients who have chronic pulmonary hypertension, but we also see it in patients who have acute or iatrogenic pulmonary hypertension. So acute pulmonary hypertension, you have a big pulmonary embolus. Iatrogenic pulmonary hypertension or reduction in pulmonary perfusion can occur when you are using significant positive pressure to recruit the lungs. So you're using high PEEPs, you're using pressure control inverse ratio, or even airway pressure release ventilation, or maybe even in your practice, you use a high frequency oscillator. Here at Grady, we primarily are going to do pressure control or high PEEP or a combination of the two, or airway pressure release ventilation. Currently, we're not really using much high frequency oscillation. Now, this is a really important concept because what I want to see is that, and I'm so sorry because that says PVCO2, but I meant to say PaCO2 minus end-tidal CO2, meaning what's left over in the arterial bed. And I'm going to fix that right now because I think it's just so important for it to say the right thing. And you'll have to correct that if you've downloaded the slides on your from my chat. And I just want to tell you, you need to correct that. PaCO2 minus end-tidal CO2. Now that's the second gap. So we talked about the first gap, which is PVACO2, venous minus arterial. And then this gap, which is PaCO2 minus end-tidal CO2, the end-tidal CO2 gap. These two gaps are going to give you so much definition about what's happening with the patient, and it's going to give you guidance on how you're going to communicate what you're asking for from your physicians, what kinds of treatments you're recommending, and just don't pretend you recommend treatments all the time. So, you know, it may be that you're in a situation or a system where they say nurses are nurses, doctors are doctors, the twains don't meet, but we all know that we are advocating all the time for our patients. And the more scientifically we advocate and the better the tools that we have, the more we can influence care for patients and hopefully direct care in the right direction because we're the ones at the bedside looking at the patient. Okay, now we understand also pulmonary ventilation, very straightforward. That's measured as end-tidal CO2. How well are you clearing end-tidal CO2? And of course, that again relates to what remains in the arterial bed after lung clearance. So really, really, really important to remember that PaCO2 is just a measure of what's left over after A, you produced it, and B, you cleared it. Production, PVCO2, clearance, end-tidal CO2, remaining arterial CO2. Very important to remember. Three distinct measures of carbon dioxide. Production, which is venous CO2, which goes up in a hyperdemand state, goes up in a metabolic acidosis state. So incredibly important. Exhalation or removal, which is what is dependent on your lung clearance, your tidal volume, your respiratory rate, and your time for exhalation. And then the passive measure, which is what remains after production has been cleared by elimination. Production cleared by elimination. What remains? Really, 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 really important. And how this affects our patient and affects the reality. So simple cartoon, nice big green line separating pre and post gas exchange at the lung and pre and post gas exchange at the cell. And then just remembering that PaCO2 is post-lung, pre-cell, PVCO2 is post-cell and pre-lung, and end-tidal is measuring what's been cleared. Now, I like things to be really simple. And actually, it's nice here because simple is correct. You may have learned something a little bit different, used something a little bit differently, but simple is really correct here. And that's what's so beautiful. What's so beautiful is we're used to looking at arterial CO2. So you see here, arterial, 35 to 45. That's the only one you have to memorize. Okay. End-tidal CO2 is typically 35 to 45, but the range of end-tidal CO2 is typically 30 to 40, 30 to 40. And venous which is the produced CO2, is typically 40 to 50. So you take arterial CO2, subtract 5, that will be the normal end tidal, even though we like it to be around the same number. Normal end tidal is 5 less on either side, so 30 to 40. And venous or production CO2 is 40 to 50, plus 5 on either side. So really straightforward and really simple. Just remember, arterial 35 to 45, plus 5 is venous on either side, minus 5 is end tidal on either side. And that's what you've got to remember when you're evaluating your patients and thinking about gaps. Now, I want to remind you again and again and again, CO2 is a product of cellular metabolism, and we actually call it cellular respiration. That's why we call CO2 the respiratory acid, not because it's cleared by the lungs, but because it's produced by cellular respiration. And it's continuously moving across the cell membrane into the circulating blood. Now, the abundance of carbon dioxide is carried bound to hemoglobin. You may not have realized that because we talk about saturation of hemoglobin, oxysaturation of hemoglobin, but also remember that hemoglobin is vital for the transporting of CO2 back to the lung, where it will dissociate, diffuse into the blood, and be cleared by the lung. Okay. Now, you have to have blood flow into the lung to clear CO2. Got to have blood flow. And you have to have open alveoli to clear CO2. But I want to remind you something about CO2. The CO2 that's presented into the pulmonary vasculature moves across that alveolar membrane into the alveoli and then out into the atmosphere about 5 to 7 times faster than oxygen diffuses into the blood. So CO2 is a rapidly moving gas, and that's why a lot of times you have to have pretty significant lung dysfunction before you actually see CO2 retention in the blood. That's why if you've got a patient who has not been retaining CO2 and then all of a sudden you see their arterial CO2 go up, you've got to ask the question, A, are you producing more? And B, are you eliminating effectively? It's always going to be very likely your patient is producing more than they can compensate for by blowing it off. So that's why it's so important to consider how vital that is, how meaningful that is, what that's going to tell us. Okay, so I just want to remind you that measuring each stage, arterial, end tidal, and venous, all 3 stages, vital and essential. Now, I'm going to mention something here right now, and it's aside from my talk. I just want to let you know, I just saw something pop up that said, your internet signal is unstable. Now, I'm in my hotel room. I have very good internet, but I'm going to ask you, if you're not hearing me speak or I'm seeming frozen to you, please just send me a quick chat to say, we don't see you, we can't hear you, so that I can reiterate my internet. And I'm very sorry. I have to apologize for that. But again, life goes on, and I love these virtual talks, so I attempt to do them no matter where I am. All right, so I want to just remind you about how all cells consume oxygen in metabolism, and always what cells are going to metabolize in the end is what we call a carbon chain. Okay, don't get all hepped up about it. Nobody's asking you to do a chemistry equation. Don't want you to get too worried. What I want you to remember is that at the end, what your cells metabolize is glucose. That's a carbon chain molecule. That's why you go into ketosis and proteolysis. You break everything down till you yield a carbon chain, and that's your glucose. So all cells, when they metabolize, are going to use carbon chain, and they need to marry that carbon chain to appropriate oxygen. So you got to have blood flow, you have to have adequate glucose in one form or another, and you must have appropriate oxygen. Okay, now what that does, what's really important is to remember that this process of breaking down the glucose is called glycolysis, and glycolysis presents the byproducts into the Krebs cycle, as we all learned 100 million years ago, and into an electron transport, which actually neutralizes and passes acids in and out of the cellular membrane, and ultimately is going to yield what we look at on our patient. So understanding that everyone is practicing in glycolysis, and that we're using oxygen for metabolism, that glycolysis, or breaking down the carbon chain, glycolysis plus oxygen are going to yield 3 things: carbon dioxide, water, and energy, ATP. Okay, really straightforward. Again, no one's asking you to be a biochemist. I'm not a biochemist. I'm trying to make this as simple as possible. But just to remember, on cellular metabolism, you'll produce CO2, water, and ATP if you are metabolizing in the presence of oxygen. But what ends up happening is to remind us that if you don't have adequate blood flow and adequate oxygen delivery, what's going to happen to you is that your ATP is going to actually decrease and your carbon dioxide is going to increase. So ATP goes down, 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 and carbon dioxide goes up, up, up. And it's really important to remember you produce more CO2 if it's anaerobic in the absence of oxygen. So again, remember, this is a really great way to say, I have poor blood flow or inadequate oxygen delivery. My patient is producing more CO2 and less ATP. And in that presence of more CO2, you actually are going to yield more metabolic acid, hydrogen ion, because of course, CO2 marries bicarb and then dissociates into hydrogen ion and carbonic acid. So more than what you care about right now, what you want to remember is that if you don't have adequate blood flow and adequate oxygen, CO2 will go up and ATP will go down, down, down. And there are three things that we think about when this occurs: that you have increased glycolysis, you have metabolic dysregulation, or that your patient is in circulatory shock. So it's pretty straightforward. This is a pretty straightforward thing. Now, this is not what you look at in arterial CO2. You're seeing this in the venous CO2 because the homeostasis of the human body is to blow that CO2 off. So when I'm concerned that you're in shock and I have a central line and an A line, you're getting a venous gas, a central venous gas, and an arterial gas drawn at the same time. And I want to look at what the process is. So again, we're thinking about pre to post production of CO2. And what's really important to say here is, again, normal central venous PV CO2, 40 to 50, normal arterial CO2, 35 to 45. And we're going to look at a gap. That's our first gap. This is the gap that should really be assisting you in evaluating patients appropriately. Remember, they have to be drawn at the same time, but I'm going to take venous CO2 and subtract the arterial CO2, and the gap should always be less than 10. Now, up to 10 is going to be acceptable. Normal gap is actually around 5. Up to 10 is going to be acceptable. Any gap beyond that is going to be concerning. Whenever you have a wide gap and you have evidence of shock or acidosis, this always indicates a poor cardiac output. There's no other answer. If you have indications of shock, you're hypotensive, you're tachycardic, you have acidosis, and you have a wide PVA CO2, vasopressors are not going to help you here. Your patient needs an increased cardiac output. So of course, your first step is volume, and then the next step is to consider the possibility of inotrope. You might even consider the possibility of packed red cells, which actually, of course, will transport oxygen to the cell and return CO2 back to the lung. Now, the cutoff of 6 is a really narrow. That means the difference of 6 suggested as an indicator to reflect an adequacy of cardiac output. But we're going to give a little wider berth to this. We're going to say closer to 10, we're going to be concerned. This is a potential indicator that reflects something that we really don't have a way to look at, and that's microcirculatory flow. So from my point of view, lots of times you all are drawing venous gases. You're drawing them from the central vein. You might not be drawing arterial gases at the same time, which from my point of view is a waste of money. You should always do a venous sample and arterial sample same time, and then look at the differences between the two. And you have to compare apples to apples. So I can't have a venous sample from 10 and try to look at it to an arterial sample from 830 because it was a different situation at that time. You have to look at it at the same time. So you draw those gases at the same time, and then you gather that information and you look at your very first gap. Okay, so post-production, that's PVCO2, minus post-elimination, that's arterial CO2, really helps you to designate where the problem is, right? If your venous CO2 is high and your arterial CO2 is high and the gap is narrow, that's most likely, not absolutely, but most likely a ventilation problem. Or it's a pulmonary perfusion problem. But when venous CO2 is high and arterial CO2 is low, that's always a production problem, and that's related to oxygen demand, glycolysis, and blood flow. Oh my God, it's just the simplest thing in the world. Simplest thing in the world. This helps us to focus on microcirculation. Okay, so why do we look at this in the gap? Okay, why do we even care about this gap? This is recognized. And one of the beautiful things here, because I know that some of you know I've been talking about this for a long time. One of the most beautiful things here is this is like one of the major aspects that's being talked about at this meeting, which was part of the reason I thought, let me talk about this again. Even though I've talked about it before, I want to really focus on it because it's talked a lot about a tool that helps us to evaluate microcirculation. And it's a simple tool, and it's a simple method of understanding. This is recognized as a tool to help us evaluate tissue perfusion. So it really needs to be part of your integrated clinical evaluation if you have a central line and an arterial line and you draw the gases at the same time. Now, content of CO2 in the venous side is determined by aerobic and anaerobic production of CO2 in the tissues, influenced by cellular metabolism, influenced by your blood flow through the pulmonary vault and your ability to breathe. But it also is very, very, very significantly and profoundly reflective of non-aerobic production of CO2. So really important in terms of how we look at our patients, how we use that data, how we're going to apply this together, what we're going to think about in terms of our way of managing patients. So by the way, does it really help to guide me? Oh my God, yes, indeed it does. PVA CO2 gap indeed increases more rapidly when you have a low cardiac output. Now, in the absence of metabolic acidosis, you might need to actually apply some interventions that are about the metabolic demand, sedation, analgesia, controlling temperature. But what's really important to appreciate is lactate is not specific. It's very sensitive, but it's not specific. Lots of different types of hyperlactatemia. We've talked about that multiple times before. And it requires liver and kidney clearance. So it may elevate, but may not be reflective of poor perfusion. This is one of the best indicators for poor perfusion that's around. So now let's just take a look at signs of circulatory shock and or lactic acidosis. Not necessary to have all of this. Okay, signs of circulatory shock and or lactic acidosis. And if you have the ability to look at an SCVO2, so maybe you drew a venous gas, and that SCVO2 is less than 70%, you need to look at your VA gap. If your VA gap is greater than 6, you've got a low cardiac output or your blood is stagnant. In either case, you need to increase cardiac output. You need to try volume and you need to try an inotrope. Your patient is hypotensive, he's acidotic, he has lost his vascular tone, but you have this problem, which tells you you don't have adequate blood flow. You're going to give volume, you're going to give an inotrope. If it's less than 6, this may be because your patient is hypoxic or because he doesn't have adequate red cell measures. He has an SVO2 less than 70%, but his gap is normal. This is not a circulatory blood flow problem. For it to be a circulatory blood flow problem, it needs to be greater than 6. Then over here, if you look at an SCVO2 greater than 70%, again, remember you just drew that gas, so you're getting that number back. If your patient has a wide PVA CO2 gap greater than 6, this could be a problem with a poor adaptation of cardiac output. Again, a lousy cardiac output, stagnant dysoxia, your blood is stagnant in the microcirculation, and it could also be a microcirculatory impairment. So one of the things you want to do on this level is that you have to actually consider that you might be using too much vasopressor. You reduce your vasopressor and increase your cardiac output. And over here, this is a cytopathic hypoxia. It's very rare. We're not going to talk about it today. But I do want to show you this inverse relationship between cardiac output and the PVA CO2 gap. So here you see cardiac output from 0 to 12. Here you see gap from 0 to 25. And you can see that when your cardiac output drops, your gap between PV and ACO2 rises. This is from a study of over 4,000 retrospective analysis of patients looking at cardiac output and correlating that to the PVA CO2 gap. As the PVA CO2 gap goes up, it means your cardiac output has gone down. This is such a great and relatively simple way for us to look at our patients. So as your gap increases, cardiac output is going down or it's inadequate to meet tissue metabolism. So why do we care about CO2 and all that gap, right? Because tissue hypoxia is the common pathway of shock. This is what actually elicits multi-organ dysfunction. So if we're in the emergency room, we're early in critical care, we're early on a step-down ward, and we're able to look at this, make recommendations for treatment, and treat patients appropriately, we can actually significantly and profoundly change outcomes. Now, it is really important to remember that this does need to always be combined with signs of shock. If the patient has no sign of shock and he has a normal lactate, he's not hypotensive, he's not tachycardic, he doesn't have a base deficit, you're not going to be nearly as worried about this PVA CO2 gap. It's going to tell you more about patient's homeostasis, and it's going to tell you more about respiratory dysfunction and metabolic dysfunction, but not in the presence of acidosis. So really important. All right, so end of gap number one, how I use PVCO2 and PaCO2 gradient. When the gap is greater than 10, PVCO2 is up and PaCO2 is down relative to the PVCO2. Might not be low, but it's relatively down because you have a gap that's wider than 10. This is a cellular blood flow problem. Straightforward as could be. If the gradient is less than 10, perfusion is okay. If the gradient is less than 10, perfusion is okay. Systemic perfusion. PVCO2 and PaCO2 may be normal or both may be elevated, but there's not a PVACO2 gap. Now, that does not mean that your pulmonary perfusion is okay. We're talking about systemic perfusion. So cellular blood flow in deficit with a gap greater than 10, and cellular blood flow okay with a gap that is less than 10. Straightforward. Okay, so now let's just take a quick look at this, okay? So here's my PVCO2, 40 to 50, my PaCO2, 35 to 45, and I want a gap of less than 6. Now, remember, I said you can go up to 10, but 6 is the magic number. Above 6, you start to have some concern. When you get close to 10, you're going to be very concerned. Okay, so this is normal. This is normal. Okay, so now I'm going to think about things that are abnormal. So I've looked at 3 things now: PaCO2, PVCO2, and the difference, PV minus A CO2. That's called the veno-arterial CO2 gap. Veno-arterial CO2 gap. So just in case you missed any of that, just to remember. Okay, now I'm going to look at the next patient. You're going to see here the patient's PVCO2 is 65 and his PaCO2 is 40. Remember what the normals are. And this patient has a normal arterial CO2, but a profoundly abnormal venous CO2. His gap is 25. When I took the VCO2 minus the arterial CO2, his gap is 25. This is a perfusion problem. This indicates either hypermetabolism without shock or poor circulatory failure or circulatory flow. So you're going to look at that patient. You're going to look at everything you've got. You're going to look at anion gap. You're going to look at the base. You're going to look at the patient's presentation. If he presents in any capillary refill, if he's presenting in any way that looks shocky, now you have some very specific, objective, scientific data. He has a wide VaCO2 gap in the presence of shock, in the presence of acidosis. You must improve his cardiac output. Okay, so one more kind of flow rhythm here that basically says you have a high gap. You could have normal perfusion or poor perfusion. That's what I want to look at. In the poor perfusion patient, arterial lactate is up, base is in deficit. Typically, they'll have a widened anion gap and their serum bicarb has gone down. If you are looking at their central gas, you did an SCVO2, your expectation is SCVO2 is down. You're going to check your patient for fluid responsiveness. If they respond to fluid, you'll give an infusion. If they do not respond to fluid, you got to give them an inotrope. This is a reason to consider an inotrope. a really important concept. So just to tie this up, I just want to remind you, metabolic acidosis, base bicarb gap, lactate, and PVA-CO2, which is the gap, okay? So when we're talking about somebody who has a base deficit, we know that that means they have a metabolic acidosis. Base in deficit, metabolic acid is up. pH is down, and I take a look at, and this gap is actually the anion gap, so we'll skip over that because we'll do that another time. But the PVA-CO2 gap is up. It's above 6. It might be close to 10. It might be beyond that. And lactate is up. And SVO2 is down, or it may be normal. What's really going to be important here is base deficit, lactate, and the PVA-CO2, reliable. Now, one thing to say is not always what it seems. If we are ventilating patients at 100%, what that does is it displaces the CO2 from the hemoglobin, because remember, hemoglobin is shared by two parties. Oxygen on the outbound blood flow to the cell, CO2 on the inbound or return blood flow to the lungs. But there's something called the Haldane effect. Haldane effect means that when I'm ventilating with 100% oxygen, I'm going to prevent the CO2 from binding to the hemoglobin, so it stays in the dissolved state. Now, that might be reflective of poor microcirculatory flow, but really, really important to remind yourself that you may be causing that CO2 to go up by ventilating patients with 100% FiO2. Now, you might not have any other choice, but just be aware of it. When you see somebody's CO2, venous CO2 going up, when they're being ventilated with 90 to 100% FiO2, just ask the doc, could this be a Haldane effect? And they will respond in kind. Wow, that's really brilliant. I have no idea what you're talking about. Yes, indeed, it might be true. We're going to try to turn the FiO2 down. I'm not sure what your docs will say, and it depends a lot on your docs and how you present your information. It also is really important to remember that acute hyperventilation with respiratory alkalosis will cause a very significant reduction in the arterial CO2. So as the arterial CO2 goes down, you're going to have a wider gap, right? Because remember, it's venous CO2 minus arterial CO2. So if the patient is hyperventilating, the arterial CO2 is down, you're going to get a wide gap. Always be cautious. You're seeing a patient that is hyperventilating as a compensatory mechanism. It's going to be really got to be really cautious here to say, but the venous CO2 is not normal, it's elevated, and the gap is wide. If the venous CO2 is normal and the arterial CO2 is down, your patient is hyperventilating, but he might not really even have a significant cause for his hyperventilation. We can use that to kind of support a diagnosis of respiratory alkalosis. So acute hyperoxia and hypocapnia are confounders in that increased PVA-CO2 gap. Remember, that gap should be less than 6, absolutely 10 or less. Always look at what is the level of PVCO2, what is the level of PaCO2, what is the gap. You need all three things together to actually make a recommendation. PVCO2 is up, arterial CO2 is down, PVCO2 is up and abnormal, PaCO2 is down, and the gap is wide, and there is the presence of any symptoms for shock. This tells you your cardiac output is inadequate, and you're going to put your attention towards improving cardiac output. Okay, so one more patient. PVCO2 is 60, PaCO2 is, PVCO2 is 65, PaCO2 is 60. Remember, normal PaCO2 is 35 to 45, normal PVCO2 40 to 50, and we have a very high venous CO2, but we also have a high arterial CO2. And the gap here is not 5, it's, the gap is 5. Sorry about that. The gap is 5. So you have a high venous, high arterial, and a normal gap. Now your question now is, because your venous is up and your arterial is up and your gap is normal, is this actually a ventilation problem? Or could it be a pulmonary perfusion problem? You don't have the answer yet. You need to perform the second gap. Okay, so now when venous CO2 is up, arterial CO2 is up, gap is normal, meaning it's not really clearly defined yet. You must look at your end tidal CO2. So that's the second gap, and this is a quick gap. It's pretty easy. Again, we use the green line to separate arterial from venous. And we remind ourselves venous is 40 to 50, arterial 35 to 45. Normal and tidal, typically we say it should be around arterial, but 30 to 40 is acceptable. 35 to 45 is much more common for what we see. And we're now going to use the Kaplan-Graham numbers. Now, we've already talked about what end-tidal CO2 is, which is clearance. The clearance of carbon dioxide depends on two things. The clearance of carbon dioxide depends on the pulmonary perfusion and the alveolar recruitment. So you can't just use end-tidal CO2 to tell you about ventilation. It's about VQ, ventilation and perfusion. So normal end-tidal CO2 typically is actually 30 to 40, but you can say 35 to 45. I don't really care. Patients who are hypoventilated because they take a long time to breathe their gas out, they're eliminating a fair amount of CO2 in that time period, and the CO2 is a volumetric measure. When they are hypoventilating, their end-tidal CO2 is typically greater than 45. They have a decreased respiratory rate and increased end-tidal per breath. They're clearing more CO2 per breath, but they're just not breathing deeply enough, rapidly enough, adequately enough to move CO2. So end-tidal CO2 per breath is up. That's what you see here, greater than 45. And the arterial CO2 is up because they are not getting rid of carbon dioxide. This is hypoventilation. So remember the case we looked at just a minute ago. We're going to see it again. 65 venous CO2, 60 arterial CO2. And then if I said to you the end-tidal CO2 was 61, you already know that patient's hypoventilated. All you need to do is address ventilatory strategies to help clear CO2. Your patient has told you what's wrong. You need to know what to do. Hyperventilation, because they're breathing really fast, they don't have enough time to clear CO2, the end-tidal CO2 goes down. It typically goes down below 35. So patients increased his respiratory rate, but the end-tidal CO2 per breath has gone down. And his PaCO2 has gone down because over a minute's period of time, this patient who is breathing really fast is clearing a lot of CO2 through the rapidity of the CO2 with each breath. Maybe not clearing as much, but clearing a lot because he's breathing rapidly over time. Now that's going to be hyperventilation. Okay, so really, really important to remember. With systemic hypoperfusion, PvCO2 is up, PaCO2 is down, and the difference between them is wide, right? That's a systemic hypoperfusion. Hyperventilation is part of the way that you deal with systemic hypoperfusion. So you're blowing off CO2 very rapidly, and arterial CO2 is down, end-tidal CO2 is down. And remember, end-tidal CO2 and arterial CO2 always go in the same direction. Here's the one that's more complicated that people have a lot of problem with, and that is when you have pulmonary hypoperfusion, because you have a PE, because you have pulmonary compression through the form of ventilatory support that you've applied to the patient, and they are not flowing blood well through the pulmonary valve. Of course, that's always the patient that you're going to think about with Flolan or nitric oxide or Velitri. They need a pulmonary dilator. You got to recruit them with the ventilator, but you got to flow their blood. Now their end-tidal is down, but both PaCO2 and PvCO2 are up. That should never be true. End-tidal should always go in the direction of PaCO2. Okay, so how lovely is this? The gradient is usually less than 6, just like the venous minus arterial, usually less than 6. Anything that gets close to 10 is concerning. End-tidal CO2 is almost always less than arterial CO2. And it really just depends on how much of the lung is open and how well perfused it is, okay? So you go to the bedside and you see a patient with an end-tidal CO2 of 20, you're looking at the patient, you're like, he's not hyperventilating, he's breathing at a normal rate. I set it at a rate, he's not breathing above the ventilator, he's breathing a normal tidal volume and a normal ventilation. When I look at his arterial CO2 at 66, now what's gonna happen here when you see this? Arterial CO2 66 and end-tidal 20, your docs are gonna increase his ventilatory support, which is actually going to make them worse, okay? But when you look at this, you say, venous CO2 76, arterial CO2 is 66. I'm not clearing this carbon dioxide. I'm not overproducing. It's only 10 above here. It's not overproduced, I just have a high level of remaining, and that's why that venous CO2 is high, because the remaining CO2 is high. So your PA CO2 is 66, your venous CO2 is 76, your end tidal is 20. You're not perfusing the lung. So in this case, what we're going to say, 3 questions that you're always going to ask here with a PA CO2 end tidal CO2 gradient. Is ventilation the problem? Is systemic perfusion the problem? Is pulmonary perfusion the problem? So when ventilation is the problem, all 3, venous, arterial, and tidal, elevated. That's the ventilation problems. Can't be any simpler than that. Venous, arterial, and end tidal, elevated. That's a ventilation problem. Systemic perfusion. Venous is elevated, but typically end tidal and arterial are low, and they're in the same direction. It's the venous that's elevated. That's the systemic perfusion. Pulmonary perfusion, very straightforward. Venous and arterial are up, end tidal is down. It's really straightforward. Now I'm going to say it again. I probably say it again somewhere in the last few slides. I'm going to say it again because I think it's really profound to hear. When ventilation is the problem, all 3 CO2s are up. Venous, arterial, and tidal. They're all elevated, and their gaps are normal. So the gap between venous and arterial, and the gap between arterial and end tidal, all normal, all less than 10, usually less than 6. Okay? When systemic perfusion is the problem, your PV CO2 is up and your arterial and end tidal are down, and you have a wide gap. You have that wide gap. Now you're hyperventilating because you're blowing off acid, and your arterial CO2 is low, but you have a wide gap between venous and arterial. That's a systemic perfusion problem. And it tells you cardiac output, in the presence of shock and other indicators, cardiac output is inadequate. And even if it's a normal cardiac output, it's not adequate for the patient. Pulmonary perfusion, the problem, that's the one that gets everybody, is I'm producing CO2, but I'm not clearing it. Okay, so venous CO2 is up, arterial CO2 is up, end tidal CO2 is down. When end tidal CO2 is down and arterial and venous CO2 are up, this is a pulmonary perfusion problem. Pretty straightforward. So now let's apply this on our patient that we looked at before. Remember, I said his gap was 5, 65 minus 60, his gap is 5. Remember, his normal PaCO2, 35 to 45, normal PVCO2, 40 to 50. He's at 65 venous, 60 arterial, gives him a normal gap. You have to look at his end tidal CO2. So, sorry, I got to do it again, animate again. His end tidal CO2 is 25. Okay, so our first gap was 5. Our second gap, I'm sorry, I said 25, but 55. Our second gap is 5. All gaps are normal. All gaps are normal. This is purely a ventilation problem. Venous CO2 up, arterial CO2 up, gap normal. Arterial CO2 up and tidal CO2 up, gap normal. All gaps normal. This is a ventilation problem. Okay. Now we're going to look again at our patient. It's probably going to animate multiple times. I'm so sorry because I thought I kind of didn't need all that animation, but it's okay. First gap, remember, our first gap was 5, venous minus arterial. So this is not a production problem. So now we're thinking, well, what about the end tidal CO2? Is end tidal CO2 gap normal, or is end tidal CO2 gap wide? I'll look at the end tidal CO2 and it's 25. Well, that is not right. Arterial CO2 minus end tidal CO2 has a gap, the second gap of 35. This is a pulmonary perfusion problem, a pulmonary perfusion problem. So this is really important because the gut reaction is arterial CO2 is up, and folks looking at that end tidal say, well, it's down. I need to make it go up, so I'm going to increase ventilation. All you're going to do is create more positive pressure in the pulmonary vault and limit the right ventricular blood flow through the pulmonary circulation. So I use PaCO2 and end tidal CO2 in a gap. And if the gradient is less than 10, right, I'm going to use my evaluation for ventilation. When the gradient is less than 10, PVCO2 is up, PaCO2 is up. the gradient is less, and end tidal CO2 is up. The gradient is less than 10. This is a ventilation problem. When the gradient of arterial to end tidal CO2 is greater than 10, I look at venous CO2 and arterial CO2. If venous and arterial CO2 are up, but end tidal CO2 is down, the gradient is wider than 10, that is a pulmonary perfusion problem, typically related to an inadequate pulmonary blood flow. Might be because of RV dysfunction, might be because of a PE. So really, really important for us to actually think about and mind these gaps. So I just want to apply these numbers to help me evaluate the care. Okay, so I'm just going to remind you here, my venous CO2 is 55, my arterial CO2 is 38. Venous is produced, 38 is what remains, and my end tidal is 33. That was what was cleared, okay? So let's apply both of our gradients, PV minus ACO2. So 55 minus 38, that's 17. That's a wide gradient. And then when I look at the end tidal CO2, these two look really significantly related to each other. So what it's telling you here is he's produced more CO2, but he's still clearing it. He's clearing more. PaCO2 and end tidal CO2 went in the same direction. So here's the thing. This is a problem of systemic perfusion. Give volume if patient's fluid responsive. If he's fluid refractory, give an inotrope. Maybe you have to give both together. If he's hypotensive, use very, and let me say that 100,000 times, very, very quickly, very low dose norepinephrine. Low dose norepinephrine. Remember, in the pursuit of pressure, you're going to make this worse. Okay, now we look over here. PvCO2 is 71, PaCO2 is 65, end tidal CO2 is 60. Okay, well, okay, PV minus A is only 6. Remember, this was wide, this was 17. Here, it's only 6. So that's a normal gradient. And the PaCO2 minus the arterial CO2 is only 5. So all the gradients are normal. He's not necessarily producing more. The reason his PvCO2 is high is because he's not clearing effectively the CO2. That's why his end tidal CO2 is high. Seems abnormal to you, I know, but that's the way it works. It's volumetric. And PaCO2 is high. So all three of them are high, and the gradients between PV and PA normal, and PA and end tidal normal. This is a ventilation problem. Here's a time where I might increase your tidal volume and or respiratory rate to increase your minute ventilation, whatever I need to do to increase minute ventilation. But what I also want to do is, if your lungs are compliant, I want to flow that gas fast and allow you to have more time for exhalation, because that's when you clear CO2. There are a lot of things you could do and that you could do differently tomorrow on your patients, tomorrow, because we react to PaCO2, we don't think about PvCO2, and we don't apply the gradients. Applying the gradients give you incredible information. Okay, so now let's look again. PvCO2 35, end tidal CO2 36, PaCO2 38. 55 to 38 is 17, 38 to 36 is 2. So the problem is, here is your PV to arterial, which is your systemic perfusion gradient. You got to give volume and or inotrope if your patient is at risk. Here's your PvCO2 of 78, end tidal is 30, PaCO2 is 61. Here you've got a high PV and a high arterial. Now the difference here is pretty high. This is 17. So you're concerned the systemic perfusion gradient is wide. You might not have very good blood flow, but also your arterial CO2, end tidal CO2 is 31, which tells you you have a lousy pulmonary perfusion. I wouldn't do anything with my ventilator here. I'd give fluid and inotrope, and I might actually consider, if my patient is shocking and having problems, I want to enhance his pulmonary perfusion. I'm going to look for whether or not he's got a PE in whatever way is easy for me to do, you know, just doing a PE echo. I'm taking you to the CT scan for the PE protocol. And if you have a PE, I'm going to get you to the cath lab, where if it's a, you know, submassive, we can do something about it. But what I want you to remember is everything here is really clear. This is not ventilation. This is perfusion. Perfusion in the perfusion from venous to arterial in the system, and perfusion in the pulmonary vault by looking at the PA to the end tidal CO2. So significant and important in terms of the way we look at our patients. Take one more patient here. Okay, PvCO2 is 78, Arterial CO2 is 68, that's a difference of 10. End tidal CO2 is 60, that's a difference of PA minus end tidal of 8. So you've got a normal gradient of perfusion in the system, a normal gradient of perfusion in the pulmonary bed. Problem is that you're not ventilated. You need to increase tidal volume, respiratory rate, and time for exhalation. Every patient that comes into your care is waiting to exhale, and they're waiting to perfuse. You have every tool that can help you to support what you're doing at the bedside in a more scientific manner in terms of how to look at perfusion, both pulmonary and systemic, and how to evaluate ventilation. It's not so simple as just looking at arterial CO2 and saying the end tidal CO2 kind of reflects the PA CO2, and that's all I really care about, because you're wasting 75% of a tool that actually has been vetted and validated time and time and time and time again, and that is now raising up in terms of its utilization in the critically ill patient and in critical care to help us determine when you need assistance with perfusion, both systemic and pulmonary, when you need assistance with ventilation, and actually when we need to help control your metabolic rates. So this is the end of gap 1 and 2, PV minus ACO2 and PaCO2 minus end tidal CO2. These are the gaps that help us to drive excellence in care. I'm so grateful that you've joined me today. I'm going to ask those who are online to stay on the line, but I'm going to end the recording now. I'm going to ask you to come back next week for the next gap discussion, which will be the anion gap and the delta anion gap, which will help us to confirm the presence of metabolic acidosis in situations where it doesn't seem so obvious. So hopefully you'll join next week on Tuesday Topic. Thank you very much for joining today, and I'll see you very, very soon.